not familiar with the Think Like a Physician webinar series, I got a small preamble for you. So here we aim to list the common and dangerous diagnoses that can potentially cause each symptom. So today we're talking about hepatocellular liver injury, not really a symptom, more a laboratory finding. Okay. And we aim to develop a basic diagnostic plan for your individual patients with the symptom in question, which is balanced between being rapid, low risk, and cost effective. Now, each of these lectures, we're going to be talking about, we start off with relevant terms and definitions, then we break into a diagnostic framework. What is the diagnostic framework? It is simply a list of diagnoses which can explain the presence of the specific symptom in question, and is organized into discrete categories. Okay, so example, in times past, we covered chest pain and we went anatomically, cardiovascular, pulmonary, GI, and so forth. However, for other topics, maybe you want to go pathophysiology. So this was pathological stratification for edema. Sometimes you go anatomical. Okay, so this is abdominal pain that we covered before. Okay, now from here we get a diagnostic algorithm, and then we talk about some clinical pearls regarding diagnostic strategy, and I give you your doggy bag of takeaway points. Righty. So, I mean, we started these lectures in February last year, and thank the Lord, I mean, we're making good progress. This is our 29th lecture in the series, and today we're talking about hepatocellular liver injury. And of course, I got some jokes for you as we go along. Speaking of which, here's the first joke. I just had a successful liver transplant operation. The surgeon really delivered. Okay, guys, here's your case for today. All right, let's dig into this, brother. 37-year-old man with a history of allogeneic stem cell transplantation at 35 years, so 2 years before we're talking about him, for chronic myelogenous leukemia complicated by cutaneous graft-versus-host disease, is admitted to the hospital with fever, skin rash, and abdominal pain. Now, the patient describes a new skin rash affecting his face, his torso, his arms, his legs, that started about 1 week before you admitted him. He has had fever and chills. Uh-oh, doesn't sound good. Development of abdominal pain prompted him to seek medical care. The medications he's on includes prednisone. No surprise because he's a stem cell recipient. So prednisone 40 milligram daily for graft-versus-host disease, and thiamate sulfur. All of us know this as Bactrim. Bactrim for prophylaxis against the infamous pneumocystis jirovecii pneumonia. There has been no recent medication changes. The patient does not take over-the-counter meds nor any herbal supplements. Very good. Now remember, guys, when we cover vignettes, every single data point is significant. So they're telling you everything here for a reason. For those of you guys who are going for exams, like herbal supplements, over-the-counter meds, there's significance to them telling us that he does not take those. Okay. Now temperature 38.6. He has scleral icterus, papillary lesions in various stages of healing. Sorry for the typo. They're healing. Are observed over the skin of the face, torso, and arms. Now some of the lesions are flaccid vesicles that are easily ungrouped, revealing serosanguinous fluid, and others appear dry and crusted. Yes, he does have a beautiful hepatomegaly, which is tender. Here is what it looks like. Ew. That's the lesion. Okay, look at this, guys. Serum ALT is a whopping 5,340. Serum AST is 4,325. So you're not messing around. This is crazy high. Alk phos is 252. Total BLE 29. INR is high at 2.8. Now, a skin lesion is swabbed for molecular identification of HSV, which is negative. Because this thing is negative. It's not herpes simplex. Okay, so the question goes on to say, which is the most likely cause of hepatocellular liver injury in this patient? Okay, is it dissemination vis-a-vis? Is it hemochromatosis, paracetamol, celiac, or ischemia? So bear this in mind, because this is our backdrop for today's talk. Okay, guys, let's get started. What exactly are liver function tests? Everybody ordered it. What are they? So they are commonly ordered panel of blood tests, which, as you might guess, evaluate liver function. All right. However, they evaluate much more than that. They also look at liver damage. They look at integrity and function of the entire biliary system, including the intrahepatic and extrahepatic ducts and the gallbladder. And they evaluate aspects of physiology outside of the hepatobiliary system altogether. For example, they provide insight into coagulation, into hemolysis, into nutrition, into bone turnover, and many, many, many other things. All right. Now, the specific tests included under the general heading of LFT are the hepatic enzymes, which are tests of synthetic function. The hepatic enzymes, tests of synthetic function, and bilirubin. Now, in common practice, there are 4 hepatic enzymes of interest: aspartate aminotransferase, AST. Then we have our beloved alanine aminotransferase, ALT. Then we have the alkaline phosphatase, which we affectionately call ALPHOS, and the gamma glutamyl transpeptidase, which is affectionately called gamma GT. Now, the AST and the ALT are collectively known as the so-called aminotransferases. Now, in addition to these 4 enzymes, the literature also frequently discusses the diagnosis of or the use of something called 5' nucleotidases. However, I've never seen that ordered, so we'll stick to aminotransferases. Okay. Now, tests of synthetic function. This is, well, how well can the liver synthesize new compounds, particularly proteins, including albumin, and something which we call the international normalized ratio, the INR. And lastly, bilirubin is subdivided into unconjugated bilirubin, which is also indirect, and conjugated or direct fractions. Now, although the indirect and direct terminology is still used in some textbooks, it is based on an outdated laboratory assay technique and has nothing to do with the physiology. If we talk about this, we're just going to talk about conjugated, unconjugated, as opposed to direct, indirect. Now, when most people use the term LFT in the clinic or in the ward, they are usually referring to a specific preset panel of blood tests, all drawn off the yellow top tube. Now, the test that is not indicated in the LFT panel includes the INR. I mean, you can't do an INR of a yellow top tube, right? But it makes sense not to include the INR since it needs to be drawn in a blue top tube. So, in addition, there are several variations on how bilirubin is reported on the LFT panel. Uncommonly, although it would make the most sense, is to report it separately as conjugated and unconjugated. So I don't want to talk too much about bilirubin because we are talking about hepatocellular liver injury, okay? So let's just talk a little bit about AST and ALT. It's important for us to understand the physiology. So AST and ALT are 2 examples of transaminases which catalyze the reaction between a keto acid and an amino acid in which the ketone and the amine groups are exchanged. Now, AST is found throughout the body, particularly in the liver. You also have it in other places like the heart, the muscle, okay, the kidneys, the red blood cells, okay? So it doesn't only live in the liver, okay? However, having said that, I'm talking about AST, eh? ALT, as opposed to AST, is predominantly just found in the liver. Therefore, increases in ALT are more specific than AST for pathology of the liver and the biliary system. Now, looking at the specific list of etiologies of increases in AST and ALT can be seen in any form of hepatocellular disease, such as cirrhosis, hepatitis, drug toxicity, fatty liver, which is steatohepatitis, and venous congestion from congestive heart failure, also known as congestive hepatopathy. It can also be seen in any form of biliary disease, okay, such as choledocholithiasis, cholecystitis, cholangitis, cholangiocarcinoma, you name it. Basically, any disease that starts with the syllable chole. I'm not talking about the Indian batsman Kohli now. He is a different Kohli. This is CHOLE, chole. Often diseases of the biliary system are collectively called cholestatic diseases, a term which serves as a parallel to hepatocellular. So in addition to hepatobiliary disease, which is the umbrella term for both hepatocellular and cholestatic disease, AST is also elevated in rhabdomyolysis, which is basically muscle breakdown, acute myocardial infarction, and hemolysis through the elevation, although the elevation in hemolysis is somewhat modest. So as previously stated, the etiologies of an increase in ALT are limited to hepatocellular and biliary disease only. Now, occasionally you may hear people informally refer to an increased AST and ALT in the absence of other overt signs of liver disease as the so-called transaminitis, okay, and that probably is acceptable as well. Okay, so let's take a look at how elevations in AST and ALT compare to one another in different disease states. So ALT in general is usually greater than AST in most chronic liver diseases that is not caused by alcohol, unless cirrhosis develops, at which point AST becomes typically greater than ALT. Now, I don't know of a specific study in which relative increases in AST versus ALT are used to screen for when a patient with chronic hepatitis has developed cirrhosis, But to me, it seems like something potentially to be looked for. Now, if the AST to ALT ratio is above 2 in a patient with probable liver disease, this is strongly suggestive of alcohol as the etiology. Now, the explanation as to why this happens is a little complex and probably beyond the scope of this lecture, but just know that an AST to ALT ratio above 5 is suggestive of an extrahepatic source of AST, such as rhabdomyolysis or an acute myocardial infarction. Okay? Um, we joke the liver is the only organ that can regrow if damaged. I'll drink to that. Oh, maybe you don't want to drink to that because you're going to chow your liver. Okay. Sorry, guys, just coming back here. Among patients with LFT increases due to liver disease, we can use the degree of elevation in formulating a differential diagnosis, since certain diseases result in a stereotypical range of ALT elevation. Okay. But I have a slide coming up later where we'll talk about this a little bit more. All righty. Okay, we did that. Okay, let's get into our diagnostic algorithm. Okay. So first up, infectious causes, hepatitis A. Now, hepatitis A infection is found worldwide, endemic in areas with poor sanitation. Now, most infected adults are symptomatic. The pre-ectic phase is characterized by symptoms that develop within 15 to 50 days, with a mean of 30 days after exposure. It's transmitted via the fecal-oral route. Okay, and this is followed by an ectic phase characterized by dark urine, acolic stools, and jaundice. Now, aminotransferases are usually markedly elevated, often over 1,000. And intrahepatic manifestations can occur like arthralgias. The diagnosis is established by detecting serum immunoglobulin M and anti-hepatitis A virus antibodies. That's a cousin of hepatitis A. This is also found worldwide. It's endemic in areas with poor sanitation. The incubation period ranges from 20 to 60 days, with a mean of 40 days. Most patients are asymptomatic, and aminotransferases are often markedly elevated, often above 1,000. Now, there are a variety of diagnostic serum assays, each with variable performance characteristics. A combination of tests may ultimately be needed to confirm this diagnosis, all right? Now, let's talk about something which is a little bit more common, hepatitis B. Now, hepatitis B infection is acquired how, guys? Via contact with infected blood or body fluid. But in the industrialized world, adults most commonly acquire the infection through sex, right? So most adults are symptomatic and clinical manifestations are similar to other forms of acute viral hepatitis. Aminotransferases are usually markedly elevated, often above 1,000. In healthy patients, this illness is self-limited in the vast majority. It progresses to acute liver failure in only under 1% of adults, which is associated with a mortality rate of approximately 80% without liver transplant. Chronic Hep B infection develops in only 5% of adult patients. Now, this is something which can cause a headache for many people, understanding hepatitis B serology, okay? In a couple of minutes just talking about this. When you order a hepatitis B panel, right, you're looking at your hepatitis B surface antigen. Then you're looking at your hepatitis B core antigen, or rather the hepatitis B core antibody, which comes in two flavors, IgM and IgG. So IgM is the acute form and IgG is the chronic form, right? Then you get your hepatitis B surface antibody, your hepatitis B E antigen, and your anti-hepatitis B E antibody. So you understand how there's a lot of things to work through. Okay. So this is a beautiful table that certifies our different infective state. Okay. Now, for me to simplify things, whenever a person is hepatitis B surface antigen positive, that just tells me that they have current infection. That doesn't really tell me whether it's acute or chronic. All it means is that at this moment in time, this patient has current hepatitis B infection, right? And if you get a hepatitis B surface antibody, that denotes immunity. Now, that immunity could be from a previous infection, that immunity could be from vaccination. I don't know, but the patient has immunity. Now, when you look at the hepatitis B core antibodies, if the patient is anti-Hep B core IgM positive, that tells me it's acute. It's an acute infection. And if the patient is hepatitis B core IgG positive, that tells me chronic infection, right? And if the hepatitis B E antigen is positive, that tells me this patient has actively replicating virus. This speaks to the infectivity of the patient, the Hep B E antigen. Okay. So if we say the patient has chronic active hepatitis, what does that mean? Well, that means it's chronic, so my anti-hepatitis B core IgG is positive, and it's active, so my hepatitis B e antigen is positive. Obviously, the patient would be hepatitis B surface antigen positive as well. Okay, if the patient has acute active hepatitis, then you expect the anti-hepatitis B core IgM to be positive, together with the anti-hepatitis, rather with hepatitis B e antigen positive and a hep B surface antigen positive. So I know it's a bit muddy, it's a bit nebulous, it's a bit cloudy. It takes a while to get used to it, guys, but that's that. Now, this lecture is not meant to talk about hepatitis B, right? So there's a lot of permutations to it. Who do you treat, who not to treat, etc. I'm not going to get into that now. This is about hepatocellular liver injury. So I just put in this slide to give you a basic idea of how to interpret hepatitis B serology. It is quite a difficult point for many people. Hepatitis C. A hep C infection is most commonly acquired how? Through blood transfusion or IV drug use. You know, for those of you guys going for exams, IV drug users, you must think number one, hepatitis C, number two, infective endocarditis, please. Okay, the two most common things. And what kind of infective endocarditis? A right-sided infective endocarditis, tricuspid valve disease. Okay. Anyway, most adults are asymptomatic. Patients who are symptomatic with hep C experience a syndrome similar to other causes of acute viral hepatitis. Aminotransferases often are markedly elevated. Now, acute hep C infection really causes acute liver failure. That's an important point to note. The hep C really causes acute liver failure. Although the illness can be self-limited, most patients develop chronic infection.
Recording in progress.
All right, so hepatitis D, really? What's about hepatitis D? Yeah, there is a hepatitis D. Um, and like hepatitis D is transmitted via contact with infected blood or body fluid. Now, infection requires the presence of either acute or chronic hepatitis B. So this is kind of like he piggybacks on top of hepatitis B. It needs the cellular machinery of hepatitis B in order to be transmitted. Now, acute co-infection typically results in a more severe clinical manifestations in comparison with just acute hepatitis B alone. And it is cleared along with hepatitis B in the vast majority of cases. In contrast, superinfection in patients with chronic hep B usually results in chronic hep D, which is associated with more rapid progression to cirrhosis. Okay, then we talk about the other viruses, Epstein-Barr virus. Most healthy patients with Epstein-Barr virus are asymptomatic. Some will experience what we call mono, infectious mononucleosis, which is characterized by a constellation of fever, sore throat, lymphadenopathy. Mild hepatocellular injury occurred. Cytomegalovirus CMV. So most healthy patients with CMV are asymptomatic, but some will experience a mononucleosis-like illness. Immunocompromised patients are at risk of primary infection or reactivation of dormant infection, which can result in tissue invasive disease, including hepatitis. Now, the spectrum of severity of CMV can range from mild to acute liver failure, and definitive diagnosis of CMV hepatitis requires histopathological evaluation of, and what we see is characteristic inclusion bodies, which has a so-called owl's eye appearance. Okay. How do we treat with ganciclovir? Okay, herpes simplex virus, of course, is in there. And this is a life-threatening condition associated with disseminated HSV1 and HSV2. It accounts for about less than 10% of viral causes of acute liver failure. Immunocompromised patients and women in the third trimester of pregnancy are at highest risk. And of course, our good old cousin, varicella zoster, VZV, chickenpox. Immunocompromised patients are at risk with disseminated VZV infection, which typically occurs as a result of deactivation of dormant infection. Okay, so I don't want to give you too much information on these viruses, but guys, together, all these infections generally cause an ALT to AST ratio, which is above 1. So in general, the ALT will be higher than the AST if you're talking about infectious causes. Okay, let's go to the next big group, and these are the toxic causes. Okay, blame it on the alcohol. Okay, we have to talk about alcohol. Alcoholic hepatitis can develop as acute or acute and chronic liver injury. Fever, jaundice, tender hepatomegaly are the hallmark of this condition. Now, unlike most other causes of toxic hepatitis, aminotransferase levels really exceed 300. So you're not going to have alcohol causing ALTs, ASTs in the thousands. No, 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 no. It's modest elevation, sometimes probably as high as about 300 or so. And here, guys, the big tip-off is the AST to ALT ratio is typically above 2. Alkaline phosphatase may be elevated, total bilirubin may be elevated, But the key thing is your AST to ALT ratio is above 2. Remember that alcohol can also cause a megaloblastic non-macrocytic anemia as well. Sometimes you may have a bump in the gamma glutamyl transferase as well. Oh, medications. Do not forget paracetamol and TB drugs. Oh, yes. Okay, so let's talk about, well, the Americans call it acetaminophen. We call it paracetamol. Okay. So how exactly does paracetamol mediate liver injury? Well, good question. Even though you didn't ask me, I asked myself. Paracetamol is metabolized in the liver, and it is metabolized by glucuronidation, sulfonation, and requires a simple 50 system of enzymes. And God gave us this beautiful complex called glutathione. Now, glutathione, it kind of scavenges free radicals and it assists in the detoxification process. But too much of paracetamol gives you too much of this metabolite called NAPQ1, N-acetyl-P benzoquinone. And benzoquinone chows your glutathione. Now, when your glutathione is low, we can't metabolize NAPP, and you end up with free radical damage to your hepatocytes. And so this has three different stages: the stage 1, stage 2, stage 3. These patients present with toxicity, nausea, vomiting, anorexia. Stage 1, stage 2, they become worse. You know, hepatotoxicity, RU pain, transaminitis, raised INR, patient going into liver failure. That signifies hepatic necrosis. And then the third one is even worse: jaundice, hepatic encephalopathy, coma, and death. Nobody wants to die. Okay, and that signifies fulminating hepatic failure. Okay, paracetamol. And we cannot talk about liver injury without mentioning TB drugs. Now, TB, drug-induced liver injury, is its own big lecture, and I'll leave that to Brother Mawela. Okay, but I just want to just highlight some of the common stuff that we see. This is taken from a beautiful article from the South African Clinicians, HIV Clinician Society, 2024 update. Okay, so everybody knows Ziffer-4, right? Rifampicin, isoniazid, pyrazinamide, ethambutol. Now, how does rifampicin cause injury? Well, it can be mixed, really. Hepatocellular, cholestatic. Remember that rifampicin colors your secretions, your urine, etc., orange, etc. And how does it cause this? It is extensively metabolized in the liver, but there's a direct toxic effect of the liver metabolites and an immune-mediated component. It may cause an asymptomatic bump in your LFTs, in your transaminases, or an isolated increase in your bilirubin. And it may cause prodromal issues as well, right? Isoniazid, the claim to fame of isoniazid is peripheral neuropathy. That is why we give what? Pyridoxine, right? We don't want our patients to end up with neuropathy, but it can affect your liver as well. Hepatocellular more than cholestasis, okay? And yeah, much the same in that respect as rifampicin. But rifampicin also can cause cholestatic, but isoniazid doesn't. Pyrazinamide, the claim to fame is it increases your uric acid and predisposes to gout. It is also very hepatotoxic, okay? And it can cause asymptomatic transient elevations, okay? With ethambutol, hey, where is ethambutol? Ethambutol does not kill your liver. Ethambutol, the claim to fame is optic neuritis, retrobulbar optic neuritis. Those patients become blind. Ethambutol is actually okay for the liver. Okay, and if you're going MDR, talking MDR stories, then moxifloxacin and levofloxacin also can cause hepatocellular cholestatic mixed injury. Okay, so just to bear in mind, guys, that drug-induced liver injury. Now, once again, this talk is not geared towards DILI, so I'm not going to be talking about how to manage DILI, etc. This is just so you guys are familiar with how these drugs mediate transaminitis and cholestasis and liver injury, essentially. Okay, that was that. That was that. Thank you so much. Okay, recreational drugs. What can we say about this? So, ecstasy. So ecstasy has a big name. It's methylene dioxymethamphetamine, MDMA, is used as a recreational drug for its euphoric effects. It can cause acute hepatitis and is responsible for a significant proportion of cases of acute liver failure in young patients. Okay, there is often marked aminotransferase elevation along with marked hyperbilirubinemia. Management is supportive. Transplant sometimes necessary. Okay, iron. Well, secondary hemochromatosis can develop as a result of increased intestinal absorption of iron or recurrent blood transfusions. Also, associated conditions include hemoglobinopathies like sickle cell, thalassemia, inherited hemolytic anemias like G6PD deficiency, and myelodysplasia. Mushrooms. Oh, we love our mushrooms. Also known as death cap, and this is the one in the Oxford Handbook that everybody knows, Amanita phalloides. is responsible for most cases of acute liver failure caused by mushroom poisoning. So clinical manifestations range from mild subclinical presentation all the way to fulminant hepatic failure. You may have some GI symptoms like abdominal pain, vomiting, diarrhea, typically appear 6 to 24 hours after ingestion. Okay, so guys, one consolidated statement about your toxic causes is that with the exception of alcoholic hepatitis, the toxic causes of hepatitis are generally associated with the ALT to AST ratio of above 1. The one exception is going to be alcohol, in which the AST to ALT ratio is higher. Okay? Vascular causes ischemia, so-called shock liver. Ischemic hepatitis occurs as a result of inadequate perfusion to the liver. Aminotransferase elevation is marked often up to 50 times the upper limit of normal. When hemodynamics are restored, there's often a rapid decrease in aminotransferases after that initial peak. So ischemia from any shock, whether it be hypovolemic, whether it be septic, whether it be cardiogenic, anything which causes diminished perfusion to the liver can induce ischemia. Okay. Congestion, so congestive hepatopathy occurs as a result of elevated central venous pressure, most commonly related to cardiomyopathy, pulmonary hypertension, constrictive pericarditis, valvulopathy. Okay, manifestations include hepatomegaly, jaundice, peripheral edema, pleural effusion, ascites, splenomegaly. Okay, so mild hyperbilirubinemia is the most common lab abnormality when present. Aminotransferase elevation in the context of congestion is mild. Okay, and then everybody's favorite Budd-Chiari syndrome, very catchy title. It's a fancy way of saying hepatic vein thrombosis. So acute Budd-Chiari is characterized by abdominal pain, hepatomegaly, ascites, and hepatocellular liver injury. Let's talk about, okay, I think I've got a slide on that. But before that, my doctor told me I need to stop drinking because I had mitosis of the liver. And I looked at him and asked him, don't you mean cirrhosis of the liver? He said, no, I drink so much my liver is trying to split with me. Hence the mitosis. Anyway, Budd-Chiari syndrome, guys. Okay, so we said it is hepatic vein thrombosis, all right? And these are the typical presentation. The patient will have cirrhosis, the patient will have ascites, and usually the ascites is out of keeping with the peripheral edema. You may have insidious portal hypertension, which can occur, acute epigastric pain. And the typical causes when indeed you have this scenario, look at your thrombophilias, your raised platelets, it could be platelet related, okay, nocturnal hemoglobin, so PNH, paroxysmal nocturnal hemoglobinuria. And the problem with PNH is that there's a problem with the GPI anchors on the red cell membranes, and they are prone to hemolysis, okay, complement mediated red cell lysis, okay, and that manifests with pancytopenia and clotting abnormalities. And so that basically plugs the hepatic vein and you get Budd-Chiari. Okay. Cancer, malignancy related, and the pill, the pill, if the patient's an oral contraceptive, that's a big risk factor for Budd-Chiari as well, or for any thrombosis for that matter. Okay. One more statement, guys, is that in terms of your vascular causes, the AST to ALT ratio is usually above 1, just like it behaves like alcohol. The AST to ALT ratio is going to be more than 1. Okay, that's that. Heredity causes, all right. So not everybody's cup of tea, but hereditary hemochromatosis is an autosomal recessive condition and is common amongst Caucasians. Now, aminotransferase levels are typically normal or only slightly up, even in patients who develop fibrotic liver disease. Now, elevated aminotransferase levels in these patients should prompt consideration of other causes of hepatocellular liver injury. So let's talk about this. Actually, this is the OSCE case. And guys, we have the FCP2 masterclass on gastroenterology coming your way on the 26th of July. So I encourage you to think about that. Yeah, so this is a typical OSCE question. Describe what you see. What disorder is this? What gene is mutated? Provide secondary causes of the disorder. Name 6 clinical manifestations. Describe the arthropathy. How do you diagnose and treat and list the complications? Okay, so I'm sure everybody already knows what this is, right? Hemochromatosis. Okay, and we talk about hook-like osteophytes, which you get in hemochromatosis. Okay, so the answer here is that the gene is HFE. Okay, it's associated with cerebrospastic anemia, thalassemia, lots and lots of manifestations. Too much iron is being absorbed and is being deposited in various organs. Okay, so it deposits in the pancreas, you end up with diabetes, in the livers, you end up with cirrhosis and liver failure, in the joints with arthritis, in the heart, cardiomyopathy, in the testes, infertility, in the skin bronzing. Okay, and the typical buzzword for the arthropathy is it affects the second and third MCP joints, causing what they call hook-like osteophytes. That's the typical finding. They love to put an OSCE exam with chondrocarcinosis, right? And how do you diagnose? Well, you can screen for it by doing your iron studies, and you'll find the ferritin is crazy high, right? You can do a liver biopsy and look for the iron content there. How do you treat it with phlebotomy and with iron chelating agent? And they love to hear the word desferrioxamine or XJADE, okay? It can complicate with liver failure, hepatic carcinoma, cardiac arrhythmias, infertility, you name it, bronze diabetes. Okay. Wilson, we're calling Mr. Wilson. Wilson's disease is most commonly diagnosed in late childhood or adolescence, but it can present later in life. It should be suspected in patients with hepatocellular liver injury and concomitant hemolytic anemia. So when you see a patient with transaminitis and hemolytic anemia, with or without psychiatric or neurological symptoms, you must think about Wilson's disease, right? And everybody knows the infamous case of Fleischer rings in the cornea. There you go. This is another famous off-key question. Describe the following. What disease is associated with the picture? Which organs are involved? How is the definitive diagnosis made? How do you treat the disorder? So this is Wilson's disease, guys. This is case of Fleischer rings because of proper deposition in Descemet's membrane. And you can see this on a slit lamp examination, okay? It deposits in the liver and brain. You want to start off by doing urine copper measurements, which are high. Your cerebral plasma is going to be low. And the gold standard test is liver biopsy, but it's not always done. And yeah, that's essentially Wilson's, okay? Why are we talking about this, guys? Clinically, hepatomegaly, the causes. So when I think about hepatomegaly, I think about 3 C's and 3 I's, okay? C for congestion, C for early cirrhosis, and C for carcinomatosis, the 3 C's. And the 3 I's are going to be infection, right? Autoimmune and infiltration, right? So 3 C's, 3 I's, you cover all your causes of hepatomegaly, okay? Which is basically encompassed in here, all right? Yes. Okay, alpha-1 antitrypsin deficiency is most often diagnosed in childhood, but in adults it may present with pulmonary or hepatic manifestations. The mechanisms of lung and liver disease differ. Remember, there's increased proteolytic activity in the lung, which leads to the development of emphysema. So whenever you see a youngster coming in, non-smoker, with low predominant emphysema, together with cirrhosis, you must do your alpha-1 antitrypsin level because that is probably a patient with alpha-1 antitrypsin deficiency. Okay, now, this is probably increasing in prevalence the world over. Non-alcoholic fatty liver disease is probably the most common cause of hepatocellular liver injury in the industrialized world. So most patients are asymptomatic or have non-specific symptoms, and the diagnosis is suspected because of mild aminotransferase elevation. There is no specific blood test for NAFLD, and it is a diagnosis of exclusion. So you can't say your patient has non-alcoholic fatty liver disease without screening for the other causes of liver disease, right? Liver biopsy can distinguish between simple steatosis and steatohepatitis, with or without fibrosis. Okay? And this is the pathophysiology, guys. So you know the infamous metabolic syndrome, right? Hypertension, diabetes, obesity, cigarette smoking, dyslipidemia, right? And that all basically affects the liver. You have de novo lipogenesis, delivery of free fatty acids, and then you get hepatic steatosis. So the liver becomes fatty. The hepatic mitochondria increase their workload to try and break down the excess free fatty acid. The increased cellular workload creates more reactive oxygen species. The free radicals cause liver damage, and that's how you progress from hepatic steatosis to steatohepatitis. Okay, ongoing inflammation damages the stellate cells. Okay, going back to those of you who study for SCP Part 1, we talk about the stellate cells and the Kupffer cells and all of that. Deposition of fibrotic material and collagen within the perisinusoidal spaces in the liver then leads to fibrosis. And ultimately, you get cirrhosis of the liver. So you see, it is a stepwise progression, okay? Hepatic steatosis leads to steatohepatitis with inflammation, which then goes to produce cirrhosis. And cirrhosis is basically chronic liver disease, end-stage liver disease. And then we got to say this is going to cause decompensated cirrhosis. And then everybody knows decompensated cirrhosis or even stable cirrhosis can cause hepatocellular carcinoma, please. Okay. And what do you mean decompensated cirrhosis? Common question in the wards. So I think about if the patient has 3 A's, right? Asterixis, ascites, and altered mentation, which is hepatic encephalopathy. These three qualify your patient as having decompensated cirrhosis as opposed to compensated cirrhosis. Okay. So 3 A's being asterixis, altered mental status, and ascites. Alrighty. Okay, non-alcoholic fatty liver disease. What about autoimmune hepatitis? This is quite a big talking point. Okay, so there's different flavors. There's type 1, type 2. I don't want to get into that too much, but basically your body is attacking the liver, okay, producing antibodies against the liver cells. And we talk about the anti-liver kidney macrosomal antibody and the anti-smooth muscle antibody together with the anti-nuclear factor. Those are your screening or your diagnostic serology. Okay, so essentially you can develop hepatic manifestations with joint pain. You can develop chronic liver disease. How do we treat this? Prednisone and azathioprine. Okay. Acute biliary obstruction. Now, although biliary obstruction will eventually cause a cholestatic pattern of liver injury, a hepatocellular pattern does occur early on. Aminotransferases are usually moderately elevated with an associated hyperbilirubinemia. The early hepatocellular predominance is explained by the fact that the aminotransferases are immediately leaked into the circulation upon hepatocyte necrosis. Now, we need some help with this one. HELP syndrome for those obstetricians in the house. This is hemolysis, elevated liver enzymes, and low platelets. All right. Okay, and it is a syndrome that develops in pregnant women. Okay, usually between the 27th and 37th weeks of gestation. The pathogenesis of HELP is somewhat unclear, but it may be a severe variant of preeclampsia. So aminotransferase elevations around 2 times upper limit of normal is required for the diagnosis. And the presence of either AST above 150 or ALT above 100 is associated with a higher risk of serious maternal mortality. Okay, celiac disease. What about celiac disease? So, hepatocellular liver injury may be the only manifestation of celiac disease. The other name for celiac, guys, is gluten-sensitive enteropathy, and you have, a variety of antibodies: anti-gliadin, anti-endomysial, anti-phosphatidylase antibodies. And the classic thing about celiac is that when you do a bowel biopsy, you find villus atrophy. Okay, and basically tell the patient to stop eating gluten. Okay, so your rye, your wheat, that kind of thing. Okay, it can cause advanced pneumonitis. Okay, guys. So we spoke a lot, and the time now is 7:20. Okay, so these are everything in a nutshell. This is a snapshot. So if you want to take a screenshot, you're welcome to take a screenshot. These are everything. So we discussed 25 causes in some detail: the infectious, the toxic, the vascular, the hereditary, and others. And others, remember, non-alcoholic fatty liver disease is probably increasing the most in prevalence, okay, because of the obesity pandemic. Probably call it a pandemic, right? um, okay, so why do they call it the liver? Because without it, you die. Therefore, it's the liver. It helps you to live. Okay, guys. Okay, so now I just put up a graph here. Okay. So among patients with liver function increases due to liver disease, we can use the degree of elevation in formulating a differential diagnosis, since certain diseases result in stereotypical range of ALT elevation. Now, the normal range of AST and ALT differs a little bit between different labs and depending on your gender. But as a general rule of thumb, the AST and ALT should be below 40 units per liter. Now, some sources advocate for a lower limit than this in chronic hepatitis B or C or with steatohepatitis. The transaminases can be near normal or even normal, and they're usually not above 2 to 300 units per liter. So this is on the x-axis, we have the actual value, and on the y-axis, we have different pathologies, okay? Now, in alcoholic hepatitis, the AST typically ranges from about 100 to 500, with ALT about one half of that. In the HELP syndrome, okay, which is a life-threatening complication in pregnancy that we just discussed, the transaminases are usually above 70 and can range into the high hundreds. Now, increases from drug toxicity, depending upon the exact situation, can be anything from barely noticeable to a value in the thousands. Now, those of us who have seen paracetamol overdose can bear testament to how high those ALTs can get in the thousands, okay? And then acute viral hepatitis, ischemic hepatitis, known colloquially as shock liver, and of course, paracetamol overdose can result in transaminases ranging from the mid-hundreds to 20,000. So when I was training here in Durban, so the gastroenterologist that I worked under, he coined the term the thousandth club, because there are just a few causes that can cause ALT or AST elevations of the thousands. And those four I mentioned here: drug toxicity, acute viral hepatitis, shock liver, paracetamol overdose. And the other one that's not here is aminosephalidase. So that will be mushroom, toxic mushroom ingestion. Okay. Okay, guys, here's a nice summary slide for us. Um, so I'm not going to focus on cholestatic liver injury. We're just looking at hepatocellular liver injury today. And a very important value you can compute is called the R value. Now, the R value is computed by taking your ALT, dividing it by the upper limit of ALT, and dividing that by the alk phos divided by the upper limit of alk phos, okay? And if your value is above 5, that speaks to hepatocellular liver injury. If it's below 2, it's cholestatic. If it's between 2 and 5, it's a mixed picture, okay? And then once you establish that you got hepatocellular injury, then you can use the degree of elevation to form a differential diagnosis. You can also use the ratio of ALT to AST or AST to ALT to also form a differential diagnosis. So if you've got a mild bump in your transaminases, you're thinking about non-alcoholic fatty liver disease, celiac disease, okay, chronic viral hepatitis, medications. Moderate elevation, okay, we're going into autoimmune hepatitis territory, acute viral hepatitis, okay. And then the thousands club, which is severe elevation, thinking about ischemic liver injury, toxic liver injury, acute viral hepatitis, mushroom poisoning, and that, right? And all that applies if the ALT is higher than the AST. But if the AST is higher than the ALT, remember we said AST is the one that doesn't only live in the liver. It comes from muscle, it comes from placenta, it comes from red cells, etc. So if you got myositis, you expect there to be a mild bump in the AST, right? And alcohol was the other thing that caused the AST to be higher than the ALT, so alcoholic hepatitis. Wilson's can do it, as well as if it's severe Budd-Chiari rhabdomyolysis, okay? Remember, guys, the half-life for ALT is long, 47 hours, and for AST is short. A nice way of remembering that ALT, L for long, AST, S for short. So the half-life of AST is much shorter than that of ALT, okay? Okay, and while we're here, I just want to quickly talk about cholestatic. So we said if your R value is below 2, it's cholestatic, right? What are the common cholestatic causes of liver function? Although I know that's not the topic for today, but stones, worms, and tumors, okay? Polydocholithiasis, which is basically gallstones in the biliary tract, okay? Strictures, malignant obstruction, AIDS cholangiopathy, okay? Worms like Ascaris, liver flu, okay? All righty. I think my doctor is hitting on me. She said I had acute liver failure. Okay, guys, we're almost at the end of it. And this is basically one of the high impact slides. Okay, putting everything together. All right, elevated transaminase. Let's go. I'm sorry it's a bit small, but go with me even as we go through this algorithm. So if you got predominantly increased AST and ALT, so we're not talking about a cholestatic picture, we're talking about a hepatocellular picture here, right? And if it's acute versus chronic, okay? So if it's acute, right? And you got a history of hypotension from whatever cause. You had shock, whether it be hypovolemic, whether it be septic or cardiogenic or spinal shock or whatever shock. Ischemic hepatitis and you manage shock. Boom, there you go. But if you find that toxicology was positive, so you did a tox screen and you find the patient had alcohol or the patient had paracetamol, the patient had some kind of anti-TB drug, then you know it's drug-induced hepatitis and you simply stop the offending agent. Okay? Now, we should always do hepatitis serologies, okay? And if it comes back positive, no surprise, viral hepatitis, usually it's self-limiting. But if the patient becomes chronically infected with Hep B or Hep C, there is a role for antivirals, right? So hepatitis B, many of the NRTIs that we use for ARVs can actually treat acute hepatitis B. And Hep C, you got to genotype the patient, and we've got a couple of agents, the first with a couple of others, but you probably want to start that in conjunction with discussing with either a gastroenterologist or an infectious disease specialist, okay? But they're very specific, nuanced situations, which is beyond the scope of today's talk, okay? Now, if you're dealing with a chronic situation and you do a right upper quadrant ultrasound and you find that, hey, you know what, I got some hepatosteatosis action, I got some cirrhosis action, then you want to screen for alcohol use, okay? And it's either positive or negative. If it's positive, you know it's alcohol-associated liver disease. You must counsel the patient, listen, you got to stop drinking, consider prednisone for high-risk patients with alcoholic hepatitis, okay? And if indeed any of these come back positive, so if metabolic syndrome is present, if your patient is got diabetes, got hypertension, dyslipidemia, etc., and fits the criteria for metabolic syndrome, consider non-alcoholic steatohepatitis or non-alcoholic fatty liver disease. And you're going to tell the patient, listen, you need to watch your diet, you need to lose weight, you need to exercise. There is a role for the SGLT2s in this scenario, vitamin E to scavenge free radicals. Pioglitazone, which is a thiazolidinedione, is one of the drugs used in type 2 diabetes, has also shown some positive effects in NAFLD, okay? And then if you're really stuck and everything else is negative, then you're thinking about the more exotic causes, okay? Do an autoimmune panel, do anti-nuclear factor, anti-liver kidney microsomal, anti-smooth muscle antibody, IgG4 levels, the plasma, 24-hour urine copper, looking for Wilson's disease, iron studies looking for hemochromatosis, alpha-1 antitrypsin. We discussed all of this, okay? And then if it comes back positive, then you know that's your diagnosis, right? So if you got a positive autoimmune panel, autoimmune hepatitis, boom, and we said the treatment is prednisone and azathioprine. If you got a low ceruloplasmin in the face of a high urine copper, you know, boom, Wilson's disease. Then you want to do a slit lamp exam, look for your Kaiser Fleischer rings, do your liver biopsy, quantify the copper content in the liver. If you find malady bodies, etc., that's Wilson's disease. If you've got a raised serum iron together with a raised transferrin stats above 50%, this is hemochromatosis. Do your genotyping with HFE gene, hemochromatosis, you do phlebotomy, you do iron chelating agents, okay? This is a beautiful slide, just bringing together everything we discussed in terms of how to investigate. Okay, my friends, that was it. Just a couple of other things I want to talk about. We offer the preparatory program for the Diploma in Internal Medicine on the CCP. This is basically what we cover. It's 3 months in duration, and we look at, this is based on past papers, and we go discipline by discipline, and we also got the segment with OSCE. I've also added an MCQ bank as well. So the last cohort, we ended off with some beautiful MCQs. Okay, and this also includes the ECG and the chest X-ray masterclass in there as well. For those of you who are going for your FCP2 exam, I know it's hectic, and working as a registrar is no joke, okay? Balancing calls with family life, with journal club presentations, with MMed, it's difficult. So these classes are stratified and streamlined to make preparation as hassle-free as possible. We have covered 6 already, and on the 26th is gastroenterology, and God willing, next month we're looking into neurology, derm, and stats, okay? And then, of course, the lab analysis workshop is happening this Saturday. This is the list of topics we got planned for you guys. Hematology in terms of all of this, and non-hematology, all of this. Blood gases, TFTs, LFTs, UNEs, CRPs, urinalysis, lipogram, you name it, it's there. Okay, this is an example of a slide taken from the lab masterclass looking at a summary of how to go through TFT interpretation, how to go about ordering TFTs. Okay, then of course the other non-FCP masterclasses we offer, mechanical ventilation. This is what we cover there. This is obviously going to be on a Saturday. It's about 6 to 7 hours. Okay, it's an example of a capnography, how to go about interpreting capnography. This is an overview of ventilator modes. This is how to set up a mechanical ventilator. So initial vent settings, right? Then of course, we also offer 2 more, the ECG and the chest X-ray masterclass. So ECG masterclass includes these, taking you from the very fundamentals through things like rate and axis, tachybrady arrhythmias, bundle branch blocks, infarction, etc. Okay. Yeah, and these are how to localize your leads, chest X-ray as well. A lot of things to cover here. This is an example of how we superimpose anatomy on the image to give you a better visualization. And of course, guys, I have a YouTube channel. All right. So feel free to check it out, Internal Medicine Algorithms and Mnemonics. I would love to have your friendship on my channel. There's a whole lot of resources there. This is an example of a topic, medications in Parkinson's, and this is an example of my homegrown acronym for the drugs that we use. Okay, guys. Now, I know our time is against us. So coming back to our clinical case, that 37, so this is a summary. It was a 37-year-old immunocompromised man. We said he had an allergenic, I think it was allergenic stem cell transplant for chronic myelogenous leukemia. And he presented with fever and abdominal pain, found to have cutaneous vesicular lesions and marked hepatocellular liver injury. Remember, his ALT and AST were above 4,000. What was the most likely cause? Okay, I'm not sure. Did you guys answer this on the... Let's have a look at the different options we had here. Okay, I'm seeing a lot of good evening. Okay, now okay, thank you, Dr. Kabongo. Dr. Kabongo says A. David says A. Nomonde says A. Elizabeth says A. Everybody is A for A. A for away. And indeed, that is the truth. Dissemination vis-a-vis. Varicella zoster. Okay. All right, guys, here's your doggy bag of takeaway points for today. Hepatocellular liver injury refers to the predominance of aminotransferase elevation compared with alk-phos. Serum bilirubin levels may or may not be also elevated. It's mild when it's less than 5 times upper limit of normal, moderate when 5 to 10 times, and marked when above 10 times. The causes, the main categories, guys, infectious, toxic, vascular, hereditary, and others. But under others is fatty liver disease, don't forget. Okay, in patients with hepatocellular liver injury, the degree of elevation and the ratio can help to narrow our differential diagnosis. Marked elevation, usually the result of acute liver injury, which is caused by acute viral infection, drug toxicity, especially paracetamol, ischemic hepatitis, autoimmune hepatitis, mushroom toxicity, Wilson's disease. Okay, here are my references, and thank you so very much, everybody. Brother Manuela.
Awesome, Brother Ryan. Yeah. Hey, this, this topic is no longer alive. You have killed it.
I hope that's in a good way.
Yes, in a good way. I think you have done justice to this topic. As you sip some water, colleagues, just remember we have our diploma preparatory programs, and registration actually opens next week. If you want to join this program for our next intake, the live sessions will start in October, November, December. I'm hoping by Christmas we'll be close to summing it up, or a few sessions early in the year. And then I think Dr. Ryan shared with you all the previous FCP Part 2 programs. If you have missed them, pulmonology, cardiology, hematology, endocrinology, rheumatology, all the ologies are available on our website. You can still go there, pick one, register, and then you'll get access. And lastly, I've been sharing on the chat there. This weekend, we are looking at lab interpretation. Please join us. And then towards the end of the month, we have gastroenterology. We are about to finish the whole human body. It's just a matter of time. All right. Thank you, colleagues. Now to go through a couple of questions which I've seen here. Dr. Kunda was asking, in terms of ALT and AST, in sepsis, which one is more sensitive? I would have thought maybe he would say between ALT and ALP. I think it would have been an obvious one. But these two, Dr. Ryan?
Nice one, Dr. Kunda. So I want to ask you, are we dealing with septic shock or just sepsis? Because septic shock will give us ischemic liver injury, alrighty, and there you expect your ALT to be higher than your AST. Okay, but if you're just talking about run-of-the-mill sepsis, gram-negative sepsis, I don't really know. I just know if it's septic shock, your ALT is going to be higher than your AST. That's ischemic liver injury. Yeah.
Yes. Yeah, I mean, these enzymes, they tend to rise together to a certain extent, but you'll have to compare. You'll find that the ALT is likely to be significantly higher than your AST. But if the cause of the shock is Puza Thursday, AST is likely to be higher than your ALT. So, colleagues, tomorrow I'm doing your LFTs as part of screening at work. Okay, Lizelle says, is there a correlation between portal hypertension, a history, and INR? I guess if I was to
Okay.
rephrase this question, do we get liver failure with portal hypertension? I guess. I don't know. Your way of responding,
Mm.
Dr. Ryan?
So good question. Okay, so now Lizelle, remember that portal hypertension can complicate cirrhosis. Okay, that's one scenario. And the other scenario is portal hypertension without cirrhosis. So if you have cirrhosis, that you can expect synthetic liver dysfunction, and your INR is going to be high because the liver can't synthesize clotting factors and can't produce bile, and bile emulsifies fats. and your clotting factors are fat soluble. Okay. But sometimes you get things like schistosomiasis, for instance, or portal vein thrombus, or Budd-Chiari, which causes portal hypertension without cirrhosis. So there, you expect your INR to be normal. Only if you have cirrhosis causing the portal hypertension will your INR be wonky. Okay? Yeah.
No, I agree with you. You know, I've seen patients who have high ALTs. They'll say liver fail. I'm like, but no. You see, INR is about whether the liver is still functioning or not. But the ALTs are just saying something is being destroyed, which is the hepatocyte. So sometimes we mix the two, hepatitis versus liver failure. So yeah, thanks for clarifying that. So Anonymous says, how often or what dose will paracetamol induce liver toxicity? So is there a specific
Mm.
cutoff? Yeah.
Okay, good question. So the books say generally above 20 tablets. So 20 tablets is 500 milligrams per tablet, which is what, 10 grams in general. But hey, you know what? If you're not sure, just give the N-acetylcysteine. And you can use, there's a normogram. It's called the Rumac-Matthew normogram, where you basically plot your paracetamol level. And that tells you whether you're toxic or not toxic. So, but in general, 20 tablets. Yeah.
Yeah. I think for my only comment, because remember I had a sore throat on Tuesday, and then I noticed that paracetamol now is included in many other things. Sometimes we count the paracetamol that is very obvious, let's say the Panado, but there's 6 other things that have paracetamol that you might be taking. You're not even
Yeah.
aware that you are, overdosing yourself. So yeah,
Yeah.
thanks for that, brother
Brother,
Ryan.
if I could quickly share a quick fun fact for you, brother. So when they looked at paracetamol overdose in the UK, they found that they actually reduced the incidence by 50% by doing something so simple. They stopped manufacturing paracetamol in bottles. They only put it in
Mm,
blister packs. And
mm.
the reason for this is they found that depressed patients don't have the motivation to peel off
Mm.
a blister pack. So if you only make it
For
available in
20
blister
tablets, it's
packs,
too much work.
exactly. But here now, when you go to Discom and Fix, you get a whole bottle, one shot.
Yeah. You just take it all like sweets. Yeah, no. I think that is
Yes.
so. Maybe we should be talking to the public health people on the prevention
Yes.
side to look at such evidence-based interventions. Thank you for that.
Yeah.
We have a lot of anonymous people, guys. I would like to call you by name, but I guess you want to be anonymous. Maybe I'm the one who typed the question, brother, right? So anonymous says, after how long does one decide to treat hepatitis B if it does not self-limit? So when do it? Maybe what are the indications to treat, particularly for the HIV or immune competent people? Because I think in my world we treat from day one. We don't even wait for the 6 months things. We just treat everybody from day one. Yeah,
Absolutely.
yeah.
Yeah. Hey, brother, this lecture was not supposed to talk about hepatitis B in detail. Because you're gonna open a can of worms now. But essentially, if your patient's in liver failure, you treat. If
Yeah,
your patient has
yeah.
cirrhosis, you treat.
Mm,
And
mm,
then you have to look at the levels of hepatitis B DNA, right? You
Viral
pull
load.
that, you look at your hepatitis viral load, sorry, yeah, viral load, look
Mm.
at the viral load, and then there's certain cut points, which I honestly don't remember offhand, right? But you know what? If you join me in the diploma program, we can revise those, right?
Awesome.
Yeah, that's all I'm gonna say for now.
Lerato is asking, can a person with fatty liver disease donate blood? Blood. Hey. What is the cause of
Okay.
the fatty? Okay, let me leave it to you, brother.
I'm
It's
having a
tricky.
bit
It's
of
too tricky for
uh,
me.
yeah, having a bit of difficulty understanding. Yeah, maybe we can give Lerato an opportunity to speak, brother. Maybe she can give us further clarity in
Yeah.
terms of what she means.
Lerato, are you in a space where you can ask live your question? Whilst the Lerato is trying to raise her hand so that I can find her. I wanted to ask you, brother Ryan.
Mm.
In my world, we tend to get patients who have HIV, they have hepatitis B, right? And maybe they are on, let's say, TLD, which controls both very nicely. Then you start them on TB treatment because there's TB, and then boom, the ALTs are going up. So sometimes we struggle to sort of determine whether is this drug induced, is this an iris from hepatitis B, or is it hepatitis B himself directly causing the insult? I don't know how you would navigate. How would you? What would be the few things maybe from a history or from clinical exam or even from the results that would say most likely drug induced or most likely hepatitis B, because even an iris itself, I don't know. I'm sure you hear what I'm trying to
Yeah,
navigate there.
loud and clear, loud and
Yeah.
clear. Difficult scenario,
Okay.
brother, to be honest. But
Yeah.
if you establish
Yeah.
a temporal relationship between starting the drug and the bump in the liver function, you can probably say it's drug-induced liver injury. If you happen to find what's the hepatitis B viral load before you started the TB treatment, then you can blame the hepatitis. But otherwise, it's a bit tricky, brother. Multifactorial, trial and error. Yeah. But if the patient has liver failure, you're going to treat the liver failure, right? Your vitamin K, your dextrose, your lactulose, you're going to
Yeah.
support the liver. Yeah,
Yeah.
that's it.
Yeah. Awesome. So I think the, like you said, the temporal relationship is what we need to figure out. Which came first, when, whether the hepatitis B was diagnosed and stable. I don't know. Yeah. But these are the scenarios I always get. And by the way, thank you. I liked that the final algorithm, which was showing the whole chain from an hepatitis, from a cholangiopathy type of scenario. So I really liked that a lot. Let me check. Lerato, let me see if I can find Lerato. Are you in a safe space, Lerato, to say hi? I think Lerato is there. Lerato, fatty liver. It will be nice to hear your voice, even if you just say no, I'm sorted. Just to hear your voice, it will be good enough for us.
Yeah, bro.
Okay, complex, difficult, but we'll try to digest. All guys, is that a feedback? You think liver enzymes are complex? How can you treat someone with hepatitis B? I think we responded to this. It depends on whether you're talking about an immune competent or someone who is immunodepleted, and yeah. But am I correct to say the first 6 months we don't treat generally for most patients?
For most
Because
patients, yeah.
they should be able to clear it on their own, and then we worry if it continues from there. Neo says, can we still give hepatitis B? Oh, PEP. You're discussing PEP for hepatitis B after a month. Is that 4 weeks is a month? I can't remember the timing. It's there in our PEP guidelines, but I would presume a month is too long. Yeah, I think it should be given within 5 to 10 days, somewhere along those lines. Now send me an email. I will send you the PEP guidelines, and you will see the timing for all the prevention things that you give after exposure. By the way, all these questions about hepatitis B and stuff, join us on the 26th. We are going to go deeper on all these questions. Let me find the link to that masterclass, because here we are just talking how do you navigate not necessarily a specific cause, but if a patient has high liver enzymes, how are you going to be navigating that? Yeah. Ryan, do you hear the owner of the house is here? Do you hear her? She's the
Yes.
close the meeting. She's bah, bah, bah. When is the HIV management postgrad open for registration? Okay. So the coaching program, again, we are restarting in October. The registration will open from next week. The next exams for the College of Medicine will be in February 2026. So usually around January or so, they will open for registration for the new cohort. They might even open late this year. So just be ready for that. When we open for, especially for HIV colleagues, ne? If you want to join the program, I would really recommend that you join timely, because I always recommend that you complete the basic and advanced HIV management courses before we start with the coaching. Those two certificates, you would attach them as part of your application to the College of Medicine. They increase your chances to be admitted. But they also make us to have very good engagements when we do the coaching. If you haven't done the basic, and it's going to be very difficult to navigate that terrain. All right. So I think I've answered that. Brother Ryan, I think I've went through all the. Oh, there, Lerato is back. Sorry, I can't verbally
Mhm.
ask. I was asking about the dangers of blood donation with a patient who. Yeah, I think Lerato, maybe Brother Ryan will talk to it. It's not about the fatty liver. We can never know about the fatty liver if you are donating, but we want to know about why you have a fatty liver. I mean, someone who's got hepatitis B should not be donating blood. I think, Brother Ryan, that is the context, right?
Mhm. Yes, absolutely. And look, I mean, patients with fatty liver, if you donate blood, right, they're going to screen your blood for HIV and hepatitis and that. I don't think it puts you at any particular increased risk of worsening liver disease. But yeah, brother, I'm actually battling to understand the context of the question.
No, I actually think she's trying to say, can you be allowed to donate? I think it's because the screening for donations does not do sonars and stuff to confirm hepatosteatosis, right?
Yes, yes.
Um, that they screen specific conditions, and if you have those conditions, you would then be excluded from
Mm.
donating. They will never know if you have a fatty liver. That I can assure you. But if the liver issue you have, and hepatitis doesn't cause a I don't know, but as far as I know, hepatitis B may not cause a fatty liver. It's caused by many other things, including ARVs.
Absolutely.
Um, yeah, so yeah. And if you have it and you're on ARVs, probably you are living with HIV, you can't be donating. So it depends on scenario by scenario why you have liver disease. And I'll just say liver disease, not necessarily fatty liver disease. Ne? I see there's a lot of questions. Dr. Ryan, we must do an information session. I think we should do a series of information sessions on the diploma
Yes,
programs
brother.
so that
Yes.
it's a build up towards the start date. I
Hmm.
saw a question. Anonymous says, where do we do the basic and advanced HIV management courses? Okay. So, firstly, these two courses are available on our website for anyone who wants to do them. These are paid courses. I think each is around 2,500 rands or something like that. If you join, you register, you join the diploma preparatory program, these two programs are already included there. You don't have to pay anything extra. That's why I encourage you to register early for the diploma. You'll get access to both programs, and we want you to complete them in a timely manner.
Hmm.
Anima says, is it the same? Yes, it's the same. So, child health was our new program. So, towards in terms of the next cohort, that will be cohort two. That means we are quite smart. It's been very intense. I can tell you that much. I'm now a baby pediatrician because I've been listening to all sorts of pediatricians coming on board and teaching on all sorts of things. So yes, it's the same. The registration opens next week. The intake will be what you call in did I say October? Ne? In October. All these programs, when you pay and register, there's already self-paced modules that you can start doing, like this one that we have just completed today. If you do internal medicine, it will be there for you to just go through them so that when we start the coaching programs, you do have some basic understanding of what's happening. So, yeah, it's exactly like that. We will do an information session and then we take it from there. So maybe let's take the last two questions, Brother Ryan, and then we call it a night. Ignatius is asking if an Ignatius attends all your part two session. So it's nice to see your question, and I know you are joining us for gastroenterology. So we must answer your question, Ignatius. If GGT is significantly raised, isn't it indicative of an obstructive process in nature? GGT?
Yeah, it's one of the cholestatic enzymes. That's absolutely correct. Sorry, did I mention gamma GT as being hepatocellular? No, it's not hepatocellular. It's cholestatic. 100% right, Ignatius.
No. I fully, and it's a very important, should I say what, companion of ALP, because remember you can also get extra hepatic ALP, but if your ALP is high and the GGT is high, usually the problem is in the liver somewhere. But I think on the 26th, Ignatius, worry not, you would go out being very empowered, right? Awesome. Okay, I see. Awesome. Thanks for the information session. Dimitri is helping us to respond. You can donate blood if you have asymptomatic fatty liver disease. Yeah. And I think some of these things we must take responsibility. If you know you are not well, you should disclose your unwellness to the SABS so that, baby pediatrician, yes, I can never be a senior. I'm even a physician, by the way. I use these algorithms. I have outreach programs that I do to support some hospitals, and I open Dr. Ryan's algorithms when I'm there, and I sound very smart, right? when I
I can ask you a small favor. Can I share
yes.
something? Can I share something quick? This is from
No, we
our
do have time. We'll
infectious.
just stop in 2 minutes time. Yeah, no stress.
Great, awesome.
Thanks,
So
brother.
this is from the infectious disease diploma session.
Yes.
Yebo. So this is what the EDL says in terms of treatment of chronic hepatitis B. So they split it into different
Yeah.
phases. So it gets quite technical here, right? And so they recommend treatment required if you hepatitis B E antigen positive, chronic hepatitis, okay? And if your DNA value is above 20,000, okay? And your ALT is elevated. So treatment is required in this scenario. Oh, sorry, I didn't give you my pointer. My pointer disappeared. There's it here. So this scenario here. And they say if you E antigen negative chronic, if your surface antigen is positive, and your DNA value is above 2000, right? And your ALT is elevated, then treatment is required. So that's the question for whoever asked about treatment of chronic hepatitis B. But remember as well, if your patient's in liver failure, your patient is cirrhotic, you're still going to treat it as well. Okay, if your patient's immunocompromised, like Brother Mavela said, the ARVs is going to treat both the hepatitis and the HIV. Yeah. Thank you, brother.
Awesome. Colleagues, that calls us to get to the end of this particular webinar. Just to say thank you for always showing up for these educational programs. And to all our members, we really appreciate you for keeping us going. If you are a non-member, I've just shared a link in the chat. There's a lot of benefits for you, as you can see there on the screen. Visit our website, join membership, have a peace of mind. Let us help you to become a better clinician. And we are getting a lot of feedback, lot of case scenarios from our colleagues on how this platform continues to enable them to be better clinicians and to be better people. So thank you, Dr. Ryan, for your commitment to empowering us. Your 2 seconds, bye-bye to the colleagues.
Nothing much else to say, brother. I hope everybody enjoyed the talk. And you need to go
Yeah.
have a seat now because you're standing for the last 90 minutes. You must go and have a seat.
Hey, brother, we sit too much during the day, some of us, in front of the computers and stuff. So, yeah, colleagues, let's call it a night. Please listen to Brother Ryan and Case discussing hemolysis. Night.
Yeah, today I'm a bit excited, so I'll ask more questions. My first question, my first question is about aptoglobin. According to my understanding, does aptoglobin do the same job as transferring to iron? Is like aptoglobin carrying the hemoglobin the same way transferring carry iron?
Excellent question, Case. I see Dr. Case is a hematologist in the making. So Case, my understanding of haptoglobin, I think of it like a mop. Right? Whenever there's lysis of red cells, it's like a mop that picks up all the excess hemoglobin. So I don't think you can make an analogy of it being like transferrin for iron. But I think that if there's hemolysis, your haptoglobin is going to mop up all that hemoglobin, and that complex causes the haptoglobin to go down. Diminished haptoglobin speaks to hemolysis happening somewhere. And you must always see it in the context of a high LDH and a high indirect bilirubin. Those three always go together. So if you've got a high LDH, a high indirect bilirubin, a low haptoglobin in a patient who has anemia, most likely you're dealing with hemolysis.